Hi, I'm Dr. Trevor Van Oostrom, one of the interventional pain physicians at Bloor Pain Specialists, and today we're going to be talking about common questions about pain medications.
What's the difference between various types of pain medications, such as acetaminophen, naproxen, or ibuprofen?
So some of the common medications that people get over the counter are tylenol and anti-inflammatories, and they're somewhat different in terms of how they work. Tylenol tends to work more centrally on the brain. It changes the way you feel pain, whereas an anti-inflammatory tends to work more peripherally on the inflammatory cascade or inflammation that occurs around joints and nerves and other structures.
When we think about how they work and what you want them to do, we really have to think about what's important to us and where the pain's coming from in order to think about whether they'll be effective and which one's better to take. Tylenol, or acetaminophen, works by tricking the brain, telling the brain, yes, I know it hurts, but I don't care. Or telling your brain not to care. It's not that important. Now, Tylenol also has some fever relieving properties, and to some degree it might have some very, very small anti-inflammatory properties. But really, it's not a true anti-inflammatory.
Tylenol as a molecule should be able to cross the blood, our bloodstream, and then go into our brain. And there's a certain gate in our brain that's responsible for sending pain signals and also helping reset our temperature. And when it works on those specific gates in our brain, it's able to hopefully bring down a pain for a patient.
True anti-inflammatories, otherwise known as non-steroidal anti-inflammatory drugs, or NSAIDs, are the anti-inflammatory class we normally think of. These are the medications like Advil, Motrin, which are both actually ibuprofen. They're just different brands for the same medication, or Aleve, which is naproxen. And the other ones in that class that are really, often seen on shelves are Voltaren. Right? That comes in a gel, Voltaren gel. So, which is diclofenac, and diclofenac can also be taken by pill form, and there are other forms as well. But the purpose of the anti-inflammatories is not to trick the brain. It's to act in the tissues. So if your knee is big, swollen, puffy, full of fluid, red, it acts in the knee.
When that happens, your body's gonna try to bring in inflammation in that area. The blood vessels are gonna get bigger. Blood flow is gonna be much increased in that area, and that'll just help promote healing in that area. But with that inflammation in those regions, you're gonna get increase in pain. And that's where your non-steroidal anti-inflammatories tend to work. Overall, the way they function is they're able to block a certain signaling pathway, and that specific pathway is responsible for inflammation in the body.
There's some important considerations with these medicines. They are very effective, but they do have a ceiling effect. So there's a maximum efficacy you can get from taking non-steroidal anti-inflammatories.
Medications are eliminated in different fashions. Some are processed through the liver, some are through the kidneys, and it really depends on the molecule. Some are processed through both organs. Tylenol is mainly processed through the liver, and in high doses can cause liver toxicity. Hence, one should always follow the manufacturer's recommended dose. For anti-inflammatories, it tends to affect the kidneys, and with daily use, one should be monitored for their kidney function to make sure that they're not causing harm.
And the other big risk factor that's been discovered, more recently, is that they do increase the risk of heart attacks, strokes, when taken over a long period of time.
I seem to only hear about opioids for treating pain. Are there other alternatives?
Yes, in fact, we have around 20-something opioids that we can use for pain. And we have a couple hundred other medications from different classes of medications that we can use for pain.
It is so common. Almost everyone, seemingly everyone, thinks about opioids as the only pain medications. And interestingly, as we know more and more and more about the effects and side effects of opioids, we learn that really they're not very effective at all. When we look at large data sets, looking at very well done trials and then comparing them to other very well done trials and including all that data, just heaps and heaps of, thousands and thousands of patients, we can really track outcomes over time and not have a single story say, hey, my aunt, she feels better, or my neighbor's neighbor has a kid who took morphine and now feels better. Well, that's one case, and that could happen with everything and anything. Some people feel better with exercises. Others feel better with psychological interventions. Other people feel better with stretches, yoga, Pilates. Other people feel better with medications or procedures like radiofrequency ablations or epidural steroid injections, which we do here at Bloor Pain Specialists. But when it comes to the actual data, when we look at averages and we look at what most people end up feeling and how most people end up doing, the vast majority of people do very similarly between placebo and opioids, which is shocking to most to hear. And it really highlights how ineffective this class is.
So in general, we try and avoid taking opiates on a regular basis because people get tolerant. Over time, they may slip into addiction, and the long-term data does not support a great outcome with chronic use of opiates.
The other thing to keep in mind with opioids is if patients are on it for a long time as well, you can develop what's called opioid-induced hyperalgesia, which basically is an ill effect of it where you're taking it for too long, and instead of actually easing your pain, you actually can develop hypersensitivity, or your pain threshold will go down, so you feel pain all the more. And there have been studies for patients who have specifically fibromyalgia that they actually have an increased level of endogenous opioids, meaning their body's own opioid levels are increased. So, and that means, that opioids may have a role in terms of causing fibromyalgia. I'm not saying that is totally the case, but there may be an association. So giving an opioid medication or prescribing an opioid medication may possibly make that worse too.
Sometimes we'll rely on some of these atypical pain medications. One might call them nerve blockers. These would be things like gabapentin, Lyrica, even some of the antidepressants like amitriptyline, or you may have heard of a drug on the television called Cymbalta. These are antidepressants that can change the way your nervous system functions and alters the way you feel about the pain. And they're very safe to take on a long-term basis if you're not experiencing side effects. So unlike some of these other drugs like anti-inflammatories that are meant for short courses to avoid hurting one's kidneys or stomach, and opiates where one might get addicted or at least tolerant, these nervous system modulators, if you will, are meant to be taken for the rest of your life if you have to. We have lots of patients who may have seizures and they take anti-seizure medications for very long periods, or they have depression and they take their antidepressants for very long periods. And so we know they're safe for long periods of time as long as you're not getting side effects, and pain is no different.
I've heard antidepressants can be used to treat pain, but I'm not depressed. How does that work?
Good question. To be honest, there are probably 20-ish, around 20 opioid medications that we use for pain, but there also are a couple of hundred medications that we can use for pain. For example, antidepressants are a group of medications that we tend to borrow from neurologists or psychiatrists that we use for pain. And we use it specifically for pain even if a patient does not have depression. And the way that medication works really is it's able to block pain signals at the spinal cord level. The way I explain it to patients usually is if you think of a soldier in battle and they get injured or shot on their leg, yet they're able to run so quickly, run quickly back to their team, to their fort. And you wonder, well, how were they able to do that? It's because they have this increased sympathetic response in their body. And that's similar to what the antidepressants are able to do in terms of bringing down pain.
Antidepressants are sometimes used for pain, and we're actually not using it for its antidepressant effect per se. But what we're using it for is to change the way the nervous system functions, if you will. There aren't many ways to do that, but antidepressants are certainly one of those ways. Through a variety of neurotransmitter changes, it can alter the function of the nervous system. And even at the level of the brain, it can change the way one processes pain, if you will. So it's not as severe.
Now, antidepressants on their own have a stigma in the name. It says depress. And so a lot of people fear, they have a sudden stop in their mind when they hear antidepressant. They're not willing to receive that information. And what I often tell my patients is that antidepressants should have been named something else. They should have been named after the way they work. They should have been named neurological enhancers, because that's all they do. These medications help our nerves fire faster and stronger, and so that they can communicate amongst each other more efficiently, and you feel like you have more energy, you can do more, pain doesn't get in the way of your life. And this is why I think that class should have been called neurological enhancers. When you think about it that way, that stigma of antidepressant effect is no longer there. And the data to show that antidepressants can help with things like back pain is profound. The data is really supportive of using that type of medication, and there are a slew of options in that class. In fact, there are different classes that all do relatively similar things. Why? Because they are all neurological enhancing drugs in terms of function of our nervous system. And that's where antidepressants come in to help reset that central processing so that we can feel more normal.
You also have seizure medications that we borrow for pain specifically. And those also, they work different from antidepressants, but they're able to block certain gates in the pain signaling pathway, peripherally from like our toe or our fingers all the way along our spinal cord. And they block those gates or channels, and in doing so, they're able to bring down or dampen the pain in a patient.
Can magnesium be used to help with muscle aches and pains? What else does it do?
Magnesium is a fantastic supplement to take. So it's one of the most benign and yet one of the most useful.
It has been shown to be helpful for muscle cramps, pain from the nervous system. It works in a variety of mechanisms. One is it can change the way, it binds to a receptor and changes the way calcium comes in and out of the cell, and that can change the conductivity of the nerves. The other way it can help is changing the way the muscle functions through almost a muscle relaxation approach. And in that way, it's a safe drug, easy to obtain, that can be tried for pain, muscle cramps, or even as a sleeping aid.
Well, as a pain medication, it can work, one, indirectly by helping a patient with their sleep. So usually I'd say, try taking it at night because it can help a patient with their sleep quality. And we know that when a patient has pain, their sleep can be hampered as well, and it can be a vicious cycle. So it can help in that regard. In terms of overall pain, the way magnesium can work is it can work on a certain channel or receptor in the brain again, called the NMDA receptor or gate, and it can help block pain signals traveling through that receptor and thus help with a patient's overall pain.
Many of us are very low in magnesium levels, even if our circulating magnesium levels are normal, because our tissues don't hold on to the magnesium. We lose magnesium through our kidneys every day, but our absorption of magnesium is very low, at 4% of whatever we're taking orally. So the more we take, the more we keep. So the more you can take, the softer your muscles can be. Now, calcium is a signaling molecule within the cells of the muscle that induce a contraction, make it stiff and hard, whereas magnesium will compete with that process and inhibit some of the nerves that will tell the muscles to release the calcium to contract. So magnesium will work on the other hand to try and soften things, cool things, calm things. Magnesium also works in the brain to reduce stress and anxiety. It is classified as what's called an anxiolytic. And by reducing our anxiety, we clench our teeth less, we have better posture, we have better sleep, we sleep longer, and we have more function throughout our day. Magnesium dosing is dependent on the side effects. Orally, magnesium can be a mild laxative. So when magnesium is taken, the more you take, the more likely it is that you go to the bathroom. So I typically tell patients to start off with a tiny dose, something like 500 milligrams, and take more and more and more every night until they have a side effect. That side effect, typically a loose stool in the morning, will tell them how much their body tolerates, and then take less than that. Be comfortable. If that's 5,000 milligrams, take 4. If that's 3,000 milligrams, take 2.5. 7,000, take 6. Take whatever your body tolerates. Now there's another side effect, and that is sleepiness. Magnesium does help us sleep, but sometimes we're too sleepy. So you want to take it in the evenings only, an hour or two before you want to go to bed, and when you feel sleepy, go to bed. In the morning though, if you can't wake up, you're really groggy, you're hitting that snooze button again and again and again, and oh my God, just turn it off. Well, maybe it's too much magnesium for you. Maybe you are absorbing too much of it. So you want to take a lower dose so that you're not inhibiting your function and you're able to wake up and go about your day.
Thank you for watching today's video. Please don't forget to like, comment, and subscribe. For questions about your care, please contact our clinic directly.